study. For the sampling section, we had 10 representatives from 3 districts. There were 50% of female. Their age range was between 22 to 71. The median was 44.14 and standard deviation was 12.46. And we have addressed Nowcott 40%, Kavarosnog 29%, Lalitpur 13%. And socioeconomic status, upper middle class 31%, lower middle class 40%, and lower class 29% was the sample. We have used translated Nepalese version of PTSD checklist for the civilian version, as the most of the sample came from the civilian. And we have used the translated Nepalese version of National Stressful Event Survey PTSD short scale for the severe survivals of PTSD, and we have used the translated Nepalese version of Junk Self-Rating Depression Scale. For the result section, we have found 18% they are suffering from PTSD. Although the Nepal mental healthcare system, they were saying that only 4% amongst the survivors they are suffering from PTSD, but this rate is so much alarming and so high. It's 18%. And among the PTSD patients, we have found 44.44% is moderately PTSD patient, 22.22% in severely, and the most alarmingly, the extreme was 33.33% of the survivors they are suffering from severe PTSD. And for the depression, all of 100 sample, the participants they were suffering from the depression. Among them, mild was 56, moderated to 19, and severe was 25%. Here is the distribution of respondents diagnosed as having PTSD by the district. As Kasparov was 13.8%, Lalitpur was 19.35%, and Nowcott for 20%. We have found a much higher result in Nowcott district because the death and devastation of the natural disaster, the earthquake was higher. That's why we have found more PTSD patients in Nowcott district. Although Nepal, the administration of Nepal, they are saying that there is a huge discrepancy and gender discrimination exists in Nepal. But in this present study, we have, for the PTSD, we have found the t-value is minus 0.270 and depression is minus 0.242. That was not significant. So we have found zero difference between male and female for these mental disorders in Nepal. If we sum up in discussion that we have said earlier is 44.44% moderately, 22.22% severe, and 33.33% on extremely suffering from PTSD. And this covers this is KK district is 13.79 for Lalitpur, 19.35, and Nowcott is 20%. They are exposed to natural disaster. Yes, the most importantly, we have put some recommendation to the government and the mental health care system. That is, we have suggested for a mass mental health care camp. Besides therapy, we need medication is important. So simultaneously, medication and psychotherapy can be operated in Nepal. And since this is a study for just within, it's completed within 15 days. So we think a longitudinal study is needed because we don't know actually what's the core concept or what's the core causes for the natural disaster, which is untouched till today. So we need a longitudinal studies. Special arrangement can be done for the vulnerable groups like women, children. It can be possible. One more thing, there's hundreds of children in Nepal. They are now orphans due to the earthquake. So child care unit can be introduced. And most importantly, there is no national mental health care system exists in Nepal. So we have suggested to build a national mental health care system. Along this thing, there is only 100 mental health care professionals they are working in Nepal, and most of them are not type. They're not psychologists, even they're not psychiatrists. Only few. I think it may be 10 or 12% they are working. but with this 10 or 12%, it's quite difficult to manage 28 million people of Nepal. So we have suggested that we can provide some psychological support from other countries, other neighboring countries like Bangladesh, from India. There might be a network, strong network can be introduced for the mental disorders for this particular region. Yes, we have some limitations since there are some items in the scales, they are not fit to our culture. Like I would like to add one thing, one item, that is that question was, are you still enjoying your sex? That is not that could not go to the fit to the our culture, our norms. It is quite violation to the norms. So more scale need to be introduced for this particular region to diagnosis the psychological disorders. Yeah. So when we say that, when we say we are here for psychological analysis or psychological study, we have faced a lot of reluctance from the participants. So that was another limitations. And yes, it is a time and money consuming study. So that's all from my part. Thank you.
Thank you very much, Dr. Ray, for presentation giving the results of your study in Nepal. Post-traumatic disorders is a very important component which needs to be taken care after disasters, as people lose not only the property but kids and kids, which lead to trauma. In fact, let me tell you, the Government of India, Ministry of Health has launched a program, National Mental Health Program, and piloted in some of the districts where they are also going to have the training of workers how to take care during emergencies and disasters. It is not the, let me make it clarify, it's not the psychiatrists, it is the counselors. And a counselor can be anybody. It can be a college student, it can be even a relative who has to take care. Municipal Corporation is going to talk about the providing primary health care during cyclone disasters.
Health Officer for Zone 3. I am a representative of Government of India and UNDP and GVMC coordinator. I have undergone for this one training primary, second and tertiary levels. One at Chennai, one at Pune, one at out of countries. Here basically we are focusing grassroots level. This is welcome to Visakhapatnam, city of destination. After that, this is a city of destruction and the early recovery with the help of the great CM Chandrababu Naidu, CEO. This is my profile, this one. My experiences here, I worked as a CAS and WHO consultant in leprosy. This is the certificate I have got, services above self by United Nations of America. This disaster management, I have given this in the United States and it was printed 2006. This is Visakhapatnam, this is airport, before and after. This is before Kailasgiri and during Cyclone Hudud. This is a zoo, International Zoo, Indira Gandhi Zoo, during Hudud cyclone. Andhra University, this is before cyclone, during cyclone, this one Hudud cyclone. This is our beach. Before that, after during cyclone, how it is. These are our heroes, the disaster management. They did central government teams and state government chief minister. This one MPs and MLAs and all department people. They are here on the main road for 9 days. This is a disaster. You can go for this disaster management. Only I am telling this one, particular preparedness and all. This entire thing, water supply, sanitation, hygiene, this blood and primary care. Mainly we are focusing on this Sagar, this community, this one cyclone centers. Cyclone centers we are having 92 kilometers, fishermen communities, 6 lakh people are staying. We are having 118 cyclone centers. These are the team, these sanitary inspectors who looking after the coastal region. This ideal cyclone center should have minimum 15 feet above the ground level. It should be 24 hours current, water, standby supply, these telephones and ham radios and everything it should be there. And standby, this in and out, the roads, everything should be provided there. See, here we are telling these primary health care centers, this disasters management. The thing is, everyone is behind this because of after all you came from the people. These centers we are going to give, we recommended to our government to hand over to the armed forces people, so that because we are getting cyclones every November and December every year. Last Hudu cyclone came, it was destroyed after 30 years. It was huge rain and 235 kilometers wind speed. So only 2 months we are afraid, November and December. That's why these buildings should be constructed such a way, 15 feet away above the columns with solid columns and 2 floors of the buildings. So entire bathrooms, 10 bathrooms for females, 10 bathrooms for ladies and gents and disability people also, and they should the ramps for disability people. So in that center, drugs should be kept such a way, 30% of buffer stock is there every time we should replace the drugs. So we are having now, our city is 18th position in India, Visakhapatnam smart city. We are now developing nearly 38 urban centers, urban community centers in coastal regions. Only coastal for fishermen communities and low socio-economical people. These centers should be constructed such a way, people should identify, they should know where to what to do, what is happening. Because fishermen community people, they will go, men will go to the sea for 1 week or 2 weeks. Only children and the females are they will stay in the houses. That is the problem. Whatever it will happen, that's why we are asking our government, our Chandrababu Naidu CM, it should be located centrally, highest position in that area. It should not be down. Previously we felt so much problem. It was one cyclone center was in the water. For that we have developed another disaster management for that evacuation of the people and air evacuation, clearance of the people. It's very difficult. That's why if we are going such a way, maybe next December 2016 December we will finish off this primary health urban centers such a way we should not lose anybody. This time also we didn't lose any human casualties, only destruction occur of properties only. Thank you very much.
My name is Balaji. I work in India Today and I have also qualified incident command system trainer for the US Forest Services. And my questions are, my concerns in fact. There are 3 issues. One is the issue of quality. Whatever we do, are we ensuring adequate quality? That's one. And I think there's another issue is especially in the healthcare, is the issue of competition. With so much of little focus by the government in terms of expenditure and available, largely it's private sector operated. And there's an intense competition in that. And if you are talking of service and competition, especially during the service, during the emergency time, in the presence of competition, somewhere it doesn't align. So are we doing anything? What are we doing to address these 2 things, quality and competition?
Let me answer you. You have raised a very good and valid question about the quality. Again, I have also mentioned that if we are imparting training to whosoever is the classes, unless you impart training, so that's why you have to have good pool of trainers who have to be trained by experience, even if from the people from outside. That's why when we started the concept of MX, we had no competence in country. We got people from the head of the medical director from New York Fire Services and others from other Columbia University and other institutions who provided training. That's very important. Second thing is about what we are doing in healthcare. Let me tell you, for disasters there was only the DM Act. But as far as the health is, we had an epidemic act which is almost centuries old act. which is very old. Now you are going to have Public Health Emergency Act, which is going to, in the bill has already been prepared by Ministry of Health, which is going to take all the responsibility. I don't think the disaster management managers will have any, it will completely shift the role of responsibility to health professions, where the Parliament will empower them to take care. They have already started. In fact, this establishment of strategic operation centers with the CDC Atlanta, creation of the centers of excellence for CBRS system, making the biosafety level of laboratory, diagnostic laboratories in various institutions, enhancing the capabilities, making the strengthening of the integrated disease surveillance for biology. Many initiatives have been taken and will take time. And like somebody mentioned about the nuclear, let me tell you, if we have got the excellent, because I had the chance to visit all the nuclear power. We have deficiency of medical services in the district hospitals around those plants. But the medical centers which are run by Nuclear Power Corporation India, they are very well trained. They have stockpile of medicine, they are very well trained. But there is a program which Ministry of Health is taking, the training of district hospitals and around nuclear plants. That is also going to be done by the Ministry of Health. There was one, yeah.
So my concern is basically that most of these healthcare centers, it's a third tier, sixth, etc. actually.
Yeah.
And number two thing, I think Mr. Balaji here raised that issue. We have been seeing a large part of responsibilities being shifted towards the private players actually, right? We saw the kind of thing which happened in case of Delhi, that for simple dengue thing, for controlling that epidemic actually, the dengue thing, right? ESMA had to be invoked to the Delhi state government, compelling the private players to admit patients coming from the lower strata of the society actually. How these things can be guaranteed when a country or a city or a state is faced with a disaster-like situation actually? In normal circumstance, they are so reluctant, private players, right? When you have a disaster, special of in nature, etc., whether these private players, they would be in position to cope up with that kind of situation or not actually. So I'd like them to...
See, along with that, while the responsibility of the public hospitals in the government sector is there, but along with that, the responsibility of private hospitals is there. If there was a road traffic accident, people would take patient to a private hospital, they would refuse. They would not, they would say, no, we'll go to take to the government hospital. Government had to issue certain instructions, various state governments have, that it is a compulsory binding. No private hospital can refuse a case during emergency.
It is already there.
That is what, see, in many hospitals were refusing, they were not even touching the patients. And even now in the disasters, you have to have, when we say make a district disaster management plan for health sector, chief medical officer of the health, who is the nodal officer, he has to make the available resources available both in the government, private, army, air force, navy, whatever are, that is a resource. You have to make, you cannot say that this is private, we leave it and government will do everything. It is a responsibility has to be shared by everyone.
Each of the speakers, there was a very strong tone of generalization. It was very generic in nature in terms of, see, we should have these drills, we should have, but I expected as an audience that it would dwell deeper into what would be the nature of action. Instead of having these larger frames as to saying that we should do this, but at a grassroots level or at the level of actuality, what should be the mode of operation? What is the best practice that you would like to give to us that we would like to factor in our policy? And yes, listening to, adding on to what these two people just said, in a situation of disaster, dengue was an epidemic, and the reason why these people did not take their ward to the private hospital is because this understanding that until unless you don't pay them a huge amount of money, these people would not let them be admitted. And this happened. This is Fortis, Fortis Max. I would like to read each one of you in the same category. That this particular person who was detected with dengue was not, the hospital authority said that you will need to bring in 1 lakh rupees and then only we would take the person, we will admit this person. So in a situation of disaster, I don't know how how does a private hospital function, and how do we factor that in?
Emergency management exercise will develop that coordination between all the agencies, and that is one of the way. Coming back to the burning question of private healthcare refusing emergency treatment, I work in a private healthcare, and I work in one of the hospitals which you mentioned, and I, as a doctor, strongly feel, see, no doctor refuses to treat a patient unless he doesn't have the resources or he is under some security threat or something like that, which happens. We need to look up what is our risk and what kind of capacity is required. Like this episode of dengue, we know very well from epidemiological study that when kids suffer from dengue, they are 5 times more vulnerable than adults. And if they become sick, they require pediatric critical care services. If we count today, even in Delhi, if another dengue epidemic comes, the number of critically ill kids will be actually more than number of critical beds available in Delhi. So we need to think of developing critical care. And to rightfully answer your question is Public Health Emergency Act. See, at the end, Delhi Government Act, they did issue orders very strongly. They even reduced the cost of the test. They said this is the cap. And most of these hospitals are managed by managers, and they take these kind of decisions. So act and strict reinforcement is the answer, and we need to take a challenge that this should not repeat.
Our hospital health, the tertiary care hospital, that to private sector, they are spending 90% of amount to the infrastructure, buildings, and publications and investigations only. Regarding what she told, rightly told, dengue, chikungunya, whatever the new diseases, they are not strictly follow what you told now also. They are not strictly following the rules and regulations also. But you made mandatory that manager or residential medical officer should go for planning of dengue, organization of dengue, logistics requirement for dengue. Then only it will be solve the problem, because these rules and regulations will be formed and policies will be formed in Assembly and Parliament that don't come into the grassroots level. If 5 lakhs rupees are there, even 5 rupees won't come into the grassroots level. This is the problem we are facing from top to the bottom level. So somewhere, some national institutes must involve in this one. They must give guidelines to our politicians, so-called our bureaucrats and IAS officers.
You see, let me tell you, there are already guidelines which clearly indicates that every registered medical practitioner has to abide and strictly follow the rules, regulations, acts, everything. If he doesn't, even directions. You are the local health authority, right?
Yes, sir.
I'll tell you, TB has been made now notifiable disease. Any patient, any private practitioner who diagnoses a case of TB has to notify to the district tuberculosis officer or the health. If you don't, you have every right to, he can even lose his license, but we don't do. The biggest challenge, biggest problem is our enforcement, even at the district level, by our own health officials. That is the biggest problem. Yes, sir. Yeah.
Sir, as managers, we have failed to a great extent in planning our resources, because we did not expect to the extent that all the PHCs will be bereft of power supply for more than 15 days to 30 days. And we could not bring back all the vaccines to one central point where power backup was there. That was the biggest calamity we could face, and we lost so much of vaccine during that period. In this regard, as the World Congress is being held at Visakhapatnam, I request the authorities that there should be a periodic training, capacity building training, at least to the district level officers for each government. Otherwise, we are unable to mobilize our resources in the right direction at the right time, because we cannot expect when the calamity comes, and the type of calamity we are faced, nobody has ever experienced like that. And most of the district is bereft of power supply for more than 3 weeks to 1 month. irrespective of the best efforts made by the state government, central government and other agencies. Because this part of India, we are in the north coastal districts, we are prone for all cyclones and all other sorts of natural calamities, and a periodic training to the health professionals in these regions is quite essential, and you can guide us in going to that direction. Thank you.
Yeah, you see that's what you are mentioning. We should not make plan and keep it in Almera. Those plans have to be rehearsed. You have to simulate those plans and then review them. What went right, what went wrong. Last question again. Yeah, even the last questions.
This is my question. I'm PS. Mr. Colson this morning only he said, because we are Visakhapatnam, we are talking of hudud and cyclone and all. We have different challenges in the mountains. I'm talking of mountains. I belong to mountains. So my question is to George. It is basically in our place a lot of accident takes place in buses because it's a mountainous area. That is one. Then we have earthquake and then landslide. And these are the more, kind of accidents which happen in our places. My question is, we are talking of very civil hospitals are there in areas very large, very scarce, and very small primary health centers are there. Doctors are very few, and everybody is dependent on doctors. When accident takes place, there are many people whom we can save if we know first aid training, if it is imparted. I'm talking of one is the community involvement. That's fine. We go and we impart training. But my point is certified first aid trainer, and then kind of workshop because every time they have to be called, and then they have to be educated. Upgradation. So first aid certified course, if it is there, I would take it to masses so that more and more they come forward and they get the certificate, and then we believe yes, they are the certified first aid trainer, they can save our life. So in that, if some agency is there, how we can mobilize this in the community?
Yes, certainly. The training can be provided to the people, members of the community. People, even lay people can be trained in first response at the basic level, which is very, very efficient in taking care of preventing multiple casualties or extending the level of damage. Now, answer to the lady's question about going into specifics. The answer is again training. There are so many different types of training that is offered by NIDM. There are many other agencies that provide training. But the answer is training. Now, incident command training, there is also the National Incident Management training that is much more specific to a person's role in taking care of a particular section of the management. So the answer is train, drill, train and drill.
For medical, because they have no competence, no capacity. It is the institutes, the medical colleges, where you train Minister of Health, premier institutions, which are required. The biological, where the mental health, the NIMHANS, the specialized institutions. If you have, like the road traffic accidents, you have now the Ministry of the Surface Transport. They said every 50 kilometers we should have a health post, train medical responders. Who's going to train them? That's not going to, Saurabh is not going to come from Delhi and train in this. It is the local people, local institutions who have to train, who have to develop manpower. So it is the state's responsibility, state's medical colleges who have to train people. And I thank you all because we have already taken a lot of time, and because of we started late and importance of the subject. Thank you very much.
Good afternoon to all of you, and thank you for coming back.